So today we'll be discussing the role of emollients. As you know, emollients are like a key thing in management of atopic dermatitis. Okay, so we'll start out with our background. So as this has been discussed in the morning, Dr. Makeo did a good job of covering what I was going to tell you in the first slide, which is basically an update on the skin structure and mainly to discuss the skin barrier. So as you know, in atopic dermatitis, what we're dealing with is inflammation. The inflammation usually occurs sometimes as a result of things which come from the external environment, or sometimes things that are going on in the internal environment. Therefore, the skin barrier is very important, and that's where the stratum corneum comes in, which forms the epidermal barrier on the skin. It's composed of corneocytes, which are usually surrounded by a continuous layer of lipids. And these lipids, we have intercellular lipids, which usually surrounds the cells in the stratum corneum. And they usually have a mixture of cyanoids, cholesterol, and free fatty acids. Then we also have hydration as a major factor here. Corneocyte hydration is also maintained by the production of natural moisturizing factors. When we talk of corneocyte hydration, it's usually maintained in the natural environment by production of the natural moisturizing factors, which are usually sourced by the breakdown of filaggrin. The maintenance of a highly organized lipid lamellae and sufficiently hydrated, tightly bound corneocytes is critical to ensuring the stratum corneum integrity. So basically in eczema, we have issues with several of those structures. So from the lipid lamellae to how tightly bound they are, to the hydration factor, and to how well bound the corneocytes are. So this is just an image that shows you where the stratum corneum is. And Dr. Makeo talked about the brick and mortar structure, so I won't go so much into that. Yeah, so when it comes to emollients, are emollients and moisturizers the same thing? These terms are often used interchangeably, and there's no standard definition for what a moisturizer is. It's actually a term that was coined by marketers. There's a traditional practice of using oils to moisturize the skin or for other factors, which was there from the past. And with time, it's been sort of renewed and refashioned. And now we've ended up with what we currently call the emollients or moisturizers. So an emollient usually fills in the cracks between the squamating corneocytes. And we can therefore say that an emollient is essentially an ingredient in a moisturizer. So not all moisturizers are emollients. So when it comes to the barrier dysfunction in atopic dermatitis, we have some few factors. We have increased loss of the total epidermal water, and this has been demonstrated even in patients who have atopic eczema and they don't actually have any lesions on their skin. We have a reduced lipid content in the stratum corneum, and mainly here, the studies that have been done have looked at the ceramides. That's what has been found to be low. And then we have poor organization and packing of lipids in the stratum corneum of lesional atopic dermatitis skin. We also have corneocytes in atopic dermatitis have been found to be a bit smaller than corneocytes in people with healthier skin. And the antimicrobial barrier as well of the skin, the stratum corneum also forms part of the antimicrobial barrier. And the skin pH in atopic dermatitis has also been found to be a bit higher than the skin pH in normal skin. Also, Dr. Makeo talked about the low variety of microbiome in atopic dermatitis skin. So all these are things that you need to have in mind when you're trying to choose an emollient for your patient. So like Dr. Makeo mentioned, we have dysbiosis. There's been found to be a clinical link between Staphylococcal aureus burden and the severity of atopic dermatitis. So usually when you have a flare, you find that you have an increased Staphylococcal aureus burden as compared to the same skin when they're not in a flare state. And staph peptides and superantigens have also been found to drive inflammation in atopic dermatitis. And Staphylococcus epidermidis has also been associated with established atopic dermatitis. So flares are known to be associated with a significant fall in skin microbiota diversity and an increase in abundance of both Staphylococcal aureus and Staphylococcal epidermidis. A small RCT that was conducted showed that a cream containing non-pathogenic Vitreocella filiformis, which is one of the microbiota that live on the skin, significantly improved atopic dermatitis. But as you know, microbiota are not equal. So this one, perhaps it will be discussed when we're discussing management, the role of the microbiome in atopic dermatitis. So like we said, the pH in skin that has atopic dermatitis has been found to be a bit higher than the pH in normal skin. And lowering of the pH in the stratum corneum has been found to reduce inflammation, to enhance permeability of the skin barrier, to enhance stratum corneum cohesion, and to improve the antimicrobial defense. So these are all things you need to keep in mind when you're selecting an emollient. So that slide just shows a list of ingredients which we consider to be emollients, which can sometimes form part of the ingredients in a moisturizer. I'll only discuss ingredients which have been studied scientifically because those are the ones we can support. So the first one is the colloidal oatmeal. This has been found to have some proteins, polysaccharides, vitamins, saponins, and enzymes, which overall have been found to be somewhat helpful to enhancing the skin barrier in atopic dermatitis. So when we talk of common creams like aqueous cream, which have been used for a very long time, there have been challenges and controversies in time concerning the use of these products. Part of the controversy is because part of the ingredients of aqueous cream is sodium. It has 1% sodium lauryl sulfate, which with time and lots of studies has been found to somehow weaken the stratum corneum. People who've used aqueous cream for a long time have been found to have a reduced stratum corneum thickness, increased total epidermal water loss, increased desquamation, and increased inflammatory protease activity. So this is the reason why aqueous cream is no longer recommended as a good moisturizer. Coconut oil is one of the products which we find often is many people recommend as a good moisturizer. But what you should know about coconut oil is that not all coconut oil is equal. Most of what has been studied is what we call virgin coconut oil. So if you're talking about virgin coconut oil, it means that the method of extraction of the oil was what we call cold pressing. Therefore, this has not been exposed to anything other than the cold pressing, and it's not been exposed to heat. So the quality of coconut oil that you're using will definitely have an impact in the outcome of the results that you get. So in itself, it's been found to be helpful in atopic dermatitis. So there are some 2 clinical trials which are conducted in the Philippines, and they found that it helps in terms of enhancing the barrier. But the challenge you should note with coconut oil is that it's very light. So if you're just putting coconut oil and then wearing clothes, then your clothes will rub off the coconut oil. So you need to keep such things in mind if you're going to recommend to someone to use that. So the next thing is lanolin, which has also been around for many years and is commonly used, especially in salons. So with lanolin, it's usually extracted from the sebaceous glands of sheep. It's usually commonly used to manage sore nipples in breastfeeding women. And studies have shown that there's a positive association between atopic dermatitis and lanolin contact allergy, just as Vanessa has mentioned to us. So perhaps it should not be one of your favorite products for someone who has eczema, because they're more likely, their skin is more likely to sensitize than perhaps someone who has healthy skin. So when it comes to ceramides are one of those products which have become the talk of town. So they are predominant lipids which naturally occur within the cell membrane in the stratum corneum at around 30 to 40%. They usually maintain the integrity of the skin barrier and are a major, what we call the mortar in the brick and mortar of the stratum corneum. And patients with eczema have been found to have low ceramide levels, hence the recent attempts for people to create emollients that have ceramides to try and replace them. So when the term pseudoceramides is used, it refers to commercially synthesized ingredients which are added to the newer moisturizers. Ceramides possess an anti-inflammatory property. They improve skin permeability and antimicrobial barrier function. So studies have shown mostly positive results with the use of ceramides, but the reason why I highlight that mostly is because different tests show different things, and there are specific things you should pay attention to, which I'll mention in the next slides. So of note is that penetration enhancers were used in preparation of ceramide creams, especially the ones that have been studied. And therefore, we do not know that if this was one of the confounding factors that showed benefit with the ceramides, because some of the studies that don't use the penetration enhancers don't get similar results. So the issue with penetration, there's usually an issue with penetration if you just use a plain ceramide. Most of it, often than not, they will not penetrate the stratum corneum, hence the use of penetration enhancers. So we have different types of ceramides, and that's an image that just shows the different molecular forms that exist. And most of the over-the-counter products that we currently have what we call the pseudoceramides, which I told you are synthetic products. So if provided in enough quantity, the pseudoceramides can work just the same as the natural ceramides. The problem is that most studies have found the amount of ceramides put in most of the commercial products are actually not enough. So probably, even though that thing says it has a ceramide, you're not getting the benefit from the ceramide itself because it's not enough. So now it's become like a marketing gimmick. So for you to have a useful ceramide, it must be accompanied by cholesterol and more than one fatty acid. Otherwise, the barrier function deteriorates rather than improving. And studies have shown that all three constituents must be provided together in equimolar ratio to restore the barrier function. So here the question is, do not fall for the claim that if a product has a ceramide, it means it's a great product. So natural moisturizing factors are water-soluble filaggrin degradation compounds. So they're actually a byproduct of your normal skin cell function. You have products like urea, pyridine, carboxylic acid, glutamic acid. They usually absorb water from the environment and ensure that the stratum corneum stays hydrated. And they also enhance the period of hydration of a moisturizer. So sometimes these are manufactured and added to moisturizers as a way of enhancing the amount of time during which that moisturizer can stay functional. So physiologic lipids, I would say these are some of the newer things that have been in the market, which are used in combination with ceramides. And these ones are topically applied physiologic lipids. And in contrast to emollients, they do not form an occlusive surface, an occlusive layer on the surface of the skin. They're usually quickly absorbed into the underlying cells where they incorporate into your own physiologic lipids. So now here they're supposed to potentiate the effect of your own natural physiologic lipids. And the big three lipids which are currently in use are cholesterol, free fatty acids, along with the ceramides. So fatty acids are critical to the barrier function as well as acting as acidifying agents and reducing inflammation. So we said atopic dermatitis skin usually has a slightly higher pH. So the fatty acids help with correction of the pH. Ideally, if you have a product that has physiologic lipids, they should have a concentration of at least 5% in the formula that you provided for it to be considered effective. So usually the ceramide is a predominant one, and that's the ratio that they have found in studies that is actually useful. And once you've managed to formulate that product with the ceramides, the cholesterol, and the free fatty acids, then you want to try and bring down the pH of the product to less than 5. which also helps correct the pH as well as manage inflammation. So there's a study by Chamlin which evaluated patients with recalcitrant atopic dermatitis on standard therapy, which included topical steroids, calcineurin inhibitors, and moisturizers. And the sole intervention was substitution of the moisturizer with the triple lipid product. And what they found is that the clinical scores improved, the epidermal barrier function was enhanced, stratum corneum cohesion also got better. So the ultrastructure of lipid-treated human epidermis has revealed enhanced lamellar membrane production, a change that was absent from patients who were previously treated with common moisturizers. A separate study on the lipids also found it was able to support that finding, and on its own, it's been said to be equivalent to using a steroid such as fluticasone on the skin. So the mechanism of action of the lipids is by inactivation of kallikreins, which usually compromise the stratum corneum structural integrity at low pH, inhibition of pathogen colonization, activation of beta-glucocerebrosidase and acidic sphingomyelinase. Then we also have certain free fatty acids which have been found to activate the PPAR receptors, which has been found to reduce inflammation. So I'll just mention some few key things which are usually added to moisturizers and see what studies have found. So the first one is tea tree oil, which is usually an essential oil originating from a plant in Australia. And it is claimed to be an anti-inflammatory, antibacterial, and antifungal. So the North American contact dermatitis group tried to test random people who are just using tea tree oil and see what effects it had. And the interesting thing is that they found the tea tree oil accounted for more than 45% of the positive reactions. And further to that, it was found that more than 50% of the people who had the reactions had a significant clinical reaction. Therefore, tea tree oil is considered a sensitizer and is not recommended for anyone with eczema especially. So when it comes to aloe vera, some studies have also been done, which it is usually claimed to have some moisturizing properties. And it's also said to have some antibacterial and antifungal properties. Most of the trials that have been done were in the field of diabetes, and it was mostly oral preparations, which have been done on topical preparations. But what has been found is that when you're working with aloe vera, they're not all equal. It depends on whether you're using a gel. Is a gel fresh? Is a gel something you bought in a store? They're said not to work the same. So for instance, if you get an aloe vera plant and you crush it, and also depending on where you grew the aloe vera plant, all those things matters to whether you're actually getting any benefits from the aloe vera plant. So the jury is still out on that one. A word on bath emollients. The issue with bath emollients is just because most people with eczema already have dry skin, and there are some soaps which are found to be even to dry out the skin even more, as well as to alter the pH on the skin. So when it comes to bath emollients, the recommendation is that, Vanessa mentioned this, so I won't go through everything, but for the part of the soap, you want to use a non-soap cleanser, and of note is that you can have a bar, which is non-soap. The soap part basically is indicating what kind of detergent they're using. So these ones have been found to at least help with a pH, but you cannot say that you'll give a soap to someone who has eczema and then they will be cured. So yeah, the other thing was about formulation. It's been found that when you can have different studies done on one product, and the formulation of each product determines whether that particular product is useful or not. Unfortunately, in our setting, you just get a product which no one tells you how it was made or what kind of formulation was used. So you're not per se in a better position to decide whether or not that product works unless you try it on patients. So I won't go through the properties of emollients because we've covered it up until here. So now we just want to answer the question of, are all moisturizers equal, and what differentiates a moisturizer from the other, and which one is the right one for your patient? So according to Cochrane studies, which reviewed multiple studies on emollients, they find that moisturizer use is recommended, and it helps reduce the number of flares. It also helps reduce the amount of topical steroids that are used to manage such patients. But the thing that they found is that different moisturizers, they can even have, you can do like 5 studies on cytomacrogol. One uses a cream, one uses an ointment, one formulates it with under different environments. They all give you different results. So the idea is that once you have an emollient which you're recommending, then ideally we should do randomized clinical trials to be in a scientific position to say whether the emollients work well or not. Patient factors, it's good to consider sometimes when you give a patient a moisturizer and they tell you this one is too oily, this one makes me sweat, this one smells bad, because it will affect the compliance. So basically, the challenges we have now is sometimes you will see a product written dermatologically tested. What does that mean? What does a product which says fragrance-free mean? Some surveys have been conducted on popular companies that make some of these emollients, and what was found is that hardly ever will they disclose to you, like if they say it's dermatologically tested, who was a dermatologist, what kind of studies did they do? Was it one dermatologist? Was it a team of dermatologists? So what's been found is that sometimes a product can claim to be dermatologist tested, but no, it wasn't really scientifically done. They could pay someone to come and say, fine, I'm the person who will say I tested your product. The other thing is that the term dermatologist recommended sells for a higher price than an emollient which doesn't have the term dermatologist recommended. Also, many products were found to actually have fragrance, which were labeled fragrance-free. So the idea is just to know that don't believe whatever you read on a label. So these are some of the considerations which basically I've already told you. And as far as ingredients are concerned, the top 3 ingredients of your moisturizer are the most relevant. And use of preservatives and additives will also affect the effect of your moisturizer. It could be a great moisturizer, then they put a preservative or an additive, which is a sensitizer. Then you find patients are using it, everyone is saying they're having a reaction. It could be perhaps not because of the main ingredient, but because of the preservatives. Yeah, so the drawbacks are issues like comedogenicity, issues like folliculitis and carbuncles, and then irritation and allergy sensitization. Yeah, so for this part, this is a recommendation of how to use emollients. Ideally, you should do 150 to 200 grams per week for children and up to 500 grams per week, which basically means if you get a big jar of what we have in the market, if you're an adult, if you're using it properly, it should be over in a week. I don't know how practical that is, but that's what the study says the recommended amount. You should use clean hands to apply. You apply in a downward direction. You should have regular and liberal use 2 to 4 times daily. 2 times is for someone who is in remission, who's not having active flares. Anyone who's having active eczema should be using a moisturizer more than twice a day. You should apply as soon as possible after a bath, no more than 3 minutes for maximum hydration. Ointments are good for very dry skin. Avoid unnecessary rubbing and massaging because it generates heat and leads to folliculitis. You continue the emollient after resolution of the eczema, which is a mistake which we mostly make. Most patients will use the emollient for up to the time the eczema clears, and then they put it aside and go back to milking jelly or something like that. Ideally, you should recommend that they continue the emollient because it will reduce the flares. So minimum twice daily use. So the take home here is that the higher the proportion of fats in a moisturizing product, the better it will keep your skin from drying. So in conclusion, you need to explain the role of emollients to your patients so that they know why they're using them. You need to direct patients to reliable sources for information because there's a lot of information on the internet and you're not going to start arguing with a patient why tea tree is good or not, and they already believe the internet more than they believe you. And there's trial and error approach until you find a suitable emollient for the reasons you explained. An emollient could have very good ingredients, but poor preservatives or something that that particular patient is allergic to. So ideally, if a patient tells you this moisturizer is not working for me, if you think the reason is something you can alter, it's okay to try and use a different emollient. Those are the new things undergoing studies. Yeah, thank you.